This technique very easy, and you can use so many patient kind of rhinoplasty. I use the cape graft after to finish the tip for the projection. Mostly I use the cephalic resection, part of the cephalic resection. For close the skin, I use the Wickreel. Now, for the suture technique, pre-op and post-op 6 months with suture technique, before and after. Before and after for the cause technique, that's the war technique after 6 months, before and after. Here you can see the war technique again. My daughter, my hubby, and my cat. We are waiting for you to attend all in one of the best rhinoplasty meeting held in Istanbul at the end of May 2025. Thank you.
Thank you very much, Dr. Nasser, for your presentation. The next speaker will be Mr. Paul Yazbek from Lebanon. He will talk about the state of art in tipplasty. Mr. Paul, he is graduated of the American University of Beirut, a degree of specialist in otolaryngology. He is a member of American Academy and European Academy of Facial. Mr. Paul, yeah, and facial plastic surgery. He has 20 years experience of rhinoplasty and revision rhinoplasty surgeries. Please, Mr. Powell, you have 15 minutes.
Good morning. Thank you, Mr. Chairman. Thank you, Dr. Tamimi, for inviting me and the other doctors from abroad. And thank you for the society and its great doctors. The previous professor discussed tipplasty, and I'm going to discuss tipplasty too, but in a different way, a little bit different way. And the tip is very important for the definition and the final result of the nose. If you do a perfect rhinoplasty and the tip is not good, you will not get a good result. There are many considerations when dealing with the tip. It's the skin, soft tissue envelope, thick skin, normal skin, thin skin. In thick skin, you need more support. In normal skin, you're okay. In thin skin, you need to do camouflage to avoid the appearance of the grafts. Other considerations are the cartilage. If it is soft, you need to put more grafts. If it's medium or hard, you're okay. If it's brittle, like in the underleaves, every time you touch it or every time you take a suture, it breaks, then you have to be careful too. The cartilage configuration at the tip, if it is bowing or inverted or rotated up, you need to derotate to fix the problem. cartilage asymmetries and cartilage disasters, especially in revisions. Patient selection is very important, and stay away from those with over expectations or those who say, I want 100% result. There is nothing 100% in rhinoplasty. Photography is very important. You need to take all these photographs. I cannot see my pointer, but it's okay. These photos show nostril asymmetry. On the two oblique views, you can see different views. You can see the nasolabial angle, the notching of the nostril, the external deviation, the difference in the lateral crury at the tip. The right one is inverted, the left is okay. So photography pre-surgery is very important, and you need to study the photographs before going into surgery. Okay, when you start the surgery, you don't use, please don't use too much of injections, because you will have a lot of swelling and different anatomy when you open up. You can use the inverted V, the step deformity, the step incision, or any incision you're comfortable with. Some doctors do the columellar incision and rim incision, and they join them at the dome. I would like to go from medial to lateral. It's easier, faster, and you can easily access the lateral crury. Then the dissection of the dorsum should be supraperitoneal, above the pericardium, and subperiosteal at the bones. Many doctors don't like this step, but I would like to free the medial crury from the overlying skin, so that when I place my sutures, I can bury them properly. There is a layer of fatty tissue and perichondrium that I would like to remove. And this layer sometimes is used as grafting material in some areas. This is a very important step that I do, and it exposes the lateral crury and shows the configuration of the lateral crury. Sometimes it shows distal inversion or mid-inversion that is camouflaged by this. When we are assessing the nose, and when you have a patient coming post-surgery and still they have fullness in this area where the cuttle is, the problem is we did not deal well with the lateral crus. So the lateral crus is what gives bulkiness in the supratip area, as you can see here. Even when we reduce the size of the lateral crus, this doesn't go. We need to rotate, like what I'm doing here. Rotate the lateral crus. This will open the valve. Oh, I have a pointer. This will open the valve and decrease the bulkiness at the. So when we have reduction, do not take more than. You have to leave more than 7 to 8 millimeters, and do a cephalic trim. Cephalic trim means you remove a little bit of the superior edge of the lateral crus. Don't go all the way there, because the lateral crus laterally is very good for valve support. And when you reduce the lateral crus laterally, you will have valve collapse and breathing problems. Okay, this is the most important. Excuse me, do you have a pointer? Hello, do you have a pointer? So this is, for me, the most important suture, along with the Gruber suture that was discussed before. We go from the inferior edge of the medial crus to the superior edge of the lateral crus. Then we go horizontally and back. We take the suture and we come in. Okay. working now? Just a point. Oh, thank you. I have no point. Okay. Okay, so you go from the inferior edge to the cephalic edge of the lateral crus, then you go inferiorly and backwards, then we go in the medial crus again, and when we suture, we rotate the lateral crus, open the valve, and remove the bulkiness. And this is the Gruber suture discussed. It reinforces this rotation. If it's not enough, by the first suture, doing this will rotate your lateral crus and open the valve and give you a better shape. Okay, the septum for harvest of the cartilage is accessed from a transmedial crural approach. And this step, although it's not it looks silly, but it's very important. This step is removal of 1 or 2 millimeters of caudal septum. It's very important because if you're going to do a tongue and groove, personally, I don't like to use this cartilage for tongue and groove because most of the time it slips off. It's a very thin cartilage. I would like to do a septal extension graft. And second, if you want to put a strut graft, you need to remove this piece because you prevent columellar show. Okay, the harvest of the cartilage, we're all ENT surgeons and we know how to do that. When you assess the patient and you look at the picture down, you see a movement of the tip down. This is the depressor septi muscle. You need to cauterize it and cut it. Because if you put strut graft here, in 1 year you will see the tip dropping down, and it may not be enough, even if it's big, and even if it's touching the base. So the use of septocolumellar graft or septal extension. Why not tongue and groove? I said before because the inferior edge of the septum is very thin and it may not hold over time. This is my personal experience. Septal extension graft is put at the septum or unilateral or bilateral, And bilateral, with this, you can push the tip down and deproject an over-rotated tip from previous surgery. Then strut graft can be used alone or with a subtle extension graft, definitely in a tongue and groove fashion. The suturing is done in tongue and groove, strut with septocolamellar graft, and this gap that you see, I will put a small piece of cartilage and close the gap, and everything will be together for full support. Okay, if you see that the tip is under tension or still pushing down, you can do, of course, the lateral crural overlay, where you release the lateral crus from the underlying tissues. You cut the lateral crus and you do overlay. This also will help in derotation. Instead of freeing the lateral crus all the way to the piriform, you can do an overlay and you can see the lateral crus derotates immediately when you do that. Then you connect the edges together by simple or mattress suture. And the overlay, you can do more rotation, and the more rotation you want, you increase the overlay. So it's a win-win situation. Of course, you can do medial crural overlay to deproject the tip in long medial cruri. There is the subdominal apex graft. If you see the narrow angle at the between the medial and the lateral crus, and the valve is not open yet as much as you want, you do a pocket, slip a piece of cartilage, and then you see the valve is more supported and it opens. Vertical area resection that was discussed. If you see asymmetry between cartilages and you want to equalize the domes, you just undermine and cut vertical area resection. Then you have to go obliquely on the lateral crus and obliquely on the medial crus in order for you, when you take your suture, to make the inversion that we discussed before on the lateral crus. So when you tie your suture, you will have the proper position and the proper dome position of the lateral crus. Tip onlay could be crushed or regular onlay. Tip onlay, I would like to use the cephalic trim that I took from the lateral crus. It's a small piece. It gives the definition and gives nice shape at the end of surgery. Tip onlay may be matched or completed by lateral crural onlay struts. These will give definition to the inferior edge of the nasal tip, giving more shape, beauty. When you have disruptions of the lateral cruri in complete inversion or like in revision surgeries, you can do total replacement or partial replacement like this one to reconstruct the lateral cruri. And at the end, dicing of cartilage and putting, mixing with blood and covering the whole dorsum, tip, and everywhere you put grafts will be very helpful, especially in thin skin patients. Take your time in closing, because the patient, even if you give them the best results, they come and say, my scar is not good, the wearing scar is not nice. Take your time. It's extra 15 minutes, but it's worth it. And thank you very much.
Our next speaker will be Dr. Ali Abdel Amir Khazal, revision like a primary rhinoplasty. He has fellowship of the Ludwig Maximilian University of Munich and rhinoplasty fellowship from Italy. Welcome, Dr. Ali.
يلا دايركت ايش يعني؟
دايركت.
Thank you, Mr. Chairman, for the introduction. I want to thank the organizing committee, especially Dr. Laith and all the team behind the scenes. And also, we are privileged to have our role model, Dr. Hani Musa Badr, the Deputy Minister of Health, and he's the biggest supporter of our specialty in the region. I'd like to talk about revision rhinoplasty. Loss of this balance, the 3D approach, creates a nasal contour that drives the attention to the nose rather than the eyes. Ideally, the nose should be balanced with a curvy linear structure and contour, drawing attention away from the nose toward the eyes. A practical approach to aesthetic in the nose begins with an accurate assessment, and this calls for 3D analysis of the entire nose. The foundation of nasal surgery is the interrelation of 3 A's: analysis, anatomy, and aesthetics. This is by Roland Daniel. And for me, it's 5 A's: analysis, 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 and then anatomy and aesthetics. Here we have the concept of the shadows and the highlights. We go back to 2006 by Dean Toryumi, who made the revolution of the change in the new concept of rhinoplasty. We don't want any discrepancy or cuts of the lines. The polygon concept by Barry Shaker. Contouring the nose requires a clear understanding of what looks normal, which method should be used to attain that normal contour. So revision rhinoplasty is either reduction, which is easier, or it is augmentation. Here we can see we need to reduce the here we can see it's an augmentation, and the difficulty in this case, at the end of the surgery, we will have a shortage of skin because it's, the dorsum is too low and it's too short. So we can do the framework, but we have to be careful about the shortage of the skin at the end of the surgery. And sometimes we have a mixed. We need to augment the tip and reduce the mid-vault to end up with that result. Again, low radix and dorsum and high supratip. So wise approach in meticulous dissection to rescue the skin and to save the remnant cartilages. And after the dissection, we have to decide whether we are going for the rib or the concha. And then we build the foundation and structure the dorsum, and eventually we go to the tip. This is the Stargates in Bergamo Museum in Berlin. This is the original one. اقترضوها من عندنا وإن شاء الله يرجعون إياها. 100 years they took it. They moved it 33,000 pieces. So we have the faked one here in Babylon, 50 kilometers from here, and the original one in Berlin in Germany. Meticulous dissection to rescue the skin and to save the remnant cartilages is very important. So we have to take time for this dissection. Don't rush, because any injury for the skin is not forgivable. So we have to take our time, and we have to be ready for any surprises. Here, this patient, she was the daughter of one of our ambassadors in Chile, in South America, and she did her rhinoplasty there, and then as a touch-up, later they inject her with this material. She came to me after 7 years of this material, and they told her it's temporary, and indeed it was not temporary, and no one knows what is this. I asked too many surgeons in the conferences, and they don't know what is this material. So we have to rescue the cartilage, and we can see here we have amalgamous mass in the tip, and we have to dissect the mucosa, skin, and the cartilages to save them. So if we compare ribs versus concha, we can see the luxury of the rib. We have too many cartilages, we have the perichondrium, and we have the fascia, in comparison to small piece of the concha. And if we want to add something to the concha, we can go to the temporalis fascia, but again, it's still few amount. And for the rib, harvesting the cartilage, we go with 2 centimeters incision, and we dissect. We don't cut the muscle, we split the muscle, and then layer by layer, we can get up the rib out. So, and then finally we ask the anesthesia for a positive pressure to ensure no pneumothorax. Again, rib with the precondylium and the fascia. So our types of reconstruction, we have 4 types. We are going to talk about structural, composite reconstruction of the dorsum. Here we have a bony cartilaginous saddling and loss of septal support, structural and aesthetic. So the beginning is with the L-strut construction and then structural onlay graft. And this, from Roland Daniel book, we have complete reconstruction, total replacement of the septum. So here we have the vertical segment and the horizontal segment. As we all know, where the septum goes, so goes the nose. So we have to So we have to build up a strong foundation, which is the septum. And it's also important when we are building our septum to take care about the angle. We have to manage the columellar labial angle when we are doing the reconstruction of the septum. So here we can see they lowered the dorsum too much and it's too much up-rotated. What we do, we elongate the length of the nose and we build up the dorsum, starting with the foundation and then structural onlay graft to give us the contour. So here the key to the whole concept of achieving a symmetric nasal pyramid in a primary and secondary rhinoplasty alike, a straight midline septum in a stable L-strut configuration. Here we can see we build up our septum. It should be in the midline and strong for the long-term result. We have to choose the strong and thin lamina from the rib to build up the nose. We can see. We can use also the remnant of the septum and support it. Here we can see we have bony part supporting the cartilage. This is a bone. This is the horizontal segment of the cartilage. Especially when we have a shortage of cartilages, we can use the bone for durability and straight midline thin layer. We can use a composite graft, bony cartilaginous and fashioned and narrow, thinner. Okay. It's also very important to support and fix our septum to the spine to confirm that it will stay at the midline. So suturing with 4 or PDS to the spine. Either we use drill or the piezo, or we can use the needle to make this hollow and then fix it. It's very important to do this step. Otherwise, we will have a pliable septum and the caudal dislocation will take place. You can see after suturing, it's in the midline and it's stable. This is a very important step, but we should not forget to fix it again, our new construct, at the cephalic part. So our L-strut complete replacement of the septum should be fixed at the spine on one side and then at the bone on the other side. We do this bony fixation, horizontal transfixation, or just a simple circlage, depend on what we want to do. Also, this suture is a nice suture to narrow the mid-vault. After building up the structure, we go to contour our dorsum using this framework or this contour, which is the SPLF and the SPLF, and it's done by my mentor Enrico Robotti and my friend Francesco Liano from Milan. It's septum, perichondrium, and fascia. And we use the perichondrium of the cartilage from the rib. We harvest it. We try to keep it on the rib, and we harvest it with the rib, because this is very useful. The perichondrium, the beauty of the perichondrium, it behaves like the bone in fixing our construct on the dorsum, because it's the precursor of the bone, so at the end it will stick. We will not have any deviation. And how we do that? We have these layers, the fascia, and the perichondrium. This is the fascia, and here is the perichondrium. What we put the perichondrium like this, perichondrium and lamina in the middle from the rib, and then above we have the fascia. And we can see we fashion and fabricate our fascia to get the exact measurements that we do. So it's adjustable. And then we bring the perichondrium, we suture it, and we make a kind of a pocket and insert the lamina inside. So the lamina is optional. If we want to augment more, we can put the lamina from the rib. If we just want to make a fine alignment of the dorsum, we just do the perichondrium and the fascia. And if we want to augment more, we can put 2 laminas. And then after that, we launch our SPLF, which is sandwiched perichondrium, lamina, and fascia, 3 layers. These are 2 guiding sutures. We go through the radix, and again, depends on where we want to put it exactly, too high or too low. Accordingly, we take the needle out. Here is our SPLF going inside the nose to take place. And then we can fix it again with a cerclage suture, but we have to be careful not to make the cerclage suture too tight to avoid the marking. Now we go to the tip and then structuring the tip. It's very important to take our time in the dissection to save and rescue the remnant of the cartilage and keep the attachment. These attachments are very important, and over that or under that we can fix our lamina or conchal cartilage from the rib or the concha, whatever. We have to be careful with this dissection not to injure the mucosa, to save the mucosa and to save the cartilage. Because these cartilage are precious, because they are cartilages of the nose. They are better than the rib and better than the concha.
Dr. Ali, you have 2 minutes, please. Okay.
And then we choose a flexible lamina because we need that flexible for the tip, and reconstruct it either overlay or underlay depending on our skin. If we have a very extreme thick skin, we can put it underlay. If we have a thick skin, it's fine. We just go with this and fix it, and that's it. Here we can see we are putting underlay in this case. We dissect, and then we put it underlay and we suture it. The same on the other side. And this is the end of our framework. So harmonic nose is very important to get the result. Here this patient did 2 surgeries in the US, and she consulted me to do a revision. We can see the collapse of the valves, so we need a strong lamina to open the valves and to improve the functional issue. And this is on-table result of the same patient. This is the same patient after 10 days. Before she traveled, she consulted me the last day, and this was the result. Another case, we did the SPLF and the framework construction. We raised the dorsum and the radix, and I will pass quickly over the pictures for the sake of time. This is the short skin we elongate the nose, we build up the dorsum, and we can see the beauty of the aesthetic lines. Another case, and here it's very important, we can use the CT reconstruction to show the deformity more clear. 2 surgeries. So this was a tertiary with a rib, and this case, we can see the mobile thing inside. She did 2 surgeries outside Iraq, and she said she didn't do any rib harvest, and I didn't know what was that. At the end, I took it out, and I built the nose, and this was the thing. And she said it was not from her, and it was not irradiated cartilage, because the irradiated cartilage is too expensive. And at the end, I knew in some countries in the region, they use the cow cartilage. It was a cow cartilage, and they didn't tell her. I just throw it, and I took a new rib, and I did the reconstruction. So to put the plan, we relies on some personal judgment, set of rules, which are the proportions, angles, geometric relationships, and number of variables, which are the strength of the cartilages, the pre-existing scarring, patient's age and sex, ethnicity, and then integrate aesthetics and anatomical standpoints to formulate a preliminary operative plan. The take-home message: for contouring the nose, we should structure the underlying anatomy that will be reflected on the skin. Work in your comfort zone, which is a different concept from life philosophy. Avoid overdoing. A remnant hub is better than saddle nose. Leave the alar base if we are not sure, if we are not mastering it. Leave a chance for a second surgeon to correct the deformity. I want to invite you to join the Rhinoplasty Society as being an active member in the Young Surgeon Committee. You can go just to the website and join it. And these are some of our latest articles. We published that in the ISABS journal. If you are interested, we got the 2nd best presentation award in Riga in the annual meeting of the Rhinoplasty Society last year. And another technique with Ferrara and Robotti, Casa Robotti Ferrara technique. It's a new article also coming. And this was the last book we published in Springer. Just published 2 months ago, and I will launch it to the WhatsApp group of our society. It's a nice book by Springer. We have 2 chapters, revision chapter by me, and the other one, hybrid chapter. And also this is a nice course in Bergamo. I will be the moderator of this course. It will take place next November. Another course in Cairo, it's next May. If you are interested, I will be the dissection part, and this also in Alexandria with our dear Professor Hassab next May also. And this is at the 2nd day after that in Istanbul by Emre Elhan, the all-in-one, if you are interested to join us. And finally, this one is Rhino Egypt, the famous Rhino Egypt week. And the Pan-Arab will be there. Thank you so much.
Thank you, Dr. Ali, for this nice lecture and good results. The next speaker is Dr. Remo Corona from Italy. His lecture about the use of navigation system in middle skull base endoscopic approach. Dr. Remo, ENT and head and neck surgery consultant at the unit of ENT of Milano in Italy. Also contract professor at School of Specialization in Milano. Really has many cooperations and activities. I will summarize. He is also a visiting fellow at the Division of Head and Neck Surgery at Hong Kong. Also a clinical observer at the Department of ENT Section Head and Neck Oncology, University of Leuven, Belgium. Please.
Thank you very much for the introduction and for the invitation, Dr. Laid. I'm very happy to be here. We go back a bit to the skull-base surgery. I'm a head and neck and skull-base surgeon. I don't do rhinoplasty. Congratulations to all the previous speakers. There were very interesting hints on that's very difficult, in my opinion, field. This is my hospital. By the way, for 2024 is the best hospital in Italy, Niguarda. When I started my career in the arena of the residency, all my mentors always told me to be a good anatomist before a surgeon, especially in some difficult fields like skull-based surgery. And yes, this is very important because we know that central skull-based surgery is somehow an understatement for sphenoid surgery. And you know that in sphenoid surgery and transsphenoidal surgery, from the endoscopic view, we have the possibility to do many different approaches, from the transpterygoid to the transsphenoidal to the clivus and sella and paracella region and to the middle cranial fossa. And as you know very well, this area is surrounded by many important neurovascular bundles and structures. We have the structures in behind the posterior wall of the maxillary sinus, the orbital apex, and the stamp of the optic nerve and the internal carotid arteries. And so, yes, of course, we have to know the anatomy, but because the central skull-based surgery is almost on the top of the in the achievements in the career of a skull-based surgeon, we have also we need also to have the right technology for doing that in a safe way. Among these technologies, like hemostatic agent, piezosurgery, microdoppler, we have the navigation system that is a very widespread and very well known. But is this technology cost-effective in doing endoscopic skull-based surgery? If we take a look to the position statement of the American Academy endorses the use of the navigation system in many situations. So you can use it, according to their statement, in almost all the difficult endoscopic cases. In particular for guiding the expert surgeon also in very complex cases, but also in improving the surgical experience and for educational purposes. If we take a look to the literature, we see that looking for image-guided surgery and sinonasal inflammatory diseases, anterior skull base, sinonasal tumor, and central skull-based surgery, we have a lack of results for this third field, almost half than the anterior skull base. But they are able to answer to these questions. In particular, what is very important to know is if it can reduce the complications of central skull-based surgery and improve the oncologic results. In this somehow recent work on the use of the intraoperative imaging in rhinology in every cases, we see that more than 80% of North American skull-based surgeons use it despite the complexity of the surgery. That the use of navigation surgery can statistically reduce the tumor recurrence in this area. You see 7.9% of recurrence in the group not prone to the use of the navigation system, to 9% in the group in which the navigation system was used. And also the major complication appear only in the group of the that not using the navigation system. Moreover, these other not so recent articles show us that the most important complications belong in that field belong to the group without the image guidance surgery using. Moreover, from the group of Brescia, we see that it is also very useful in the preclinical setting to assess the type of treatment and to assess the surgical corridor to the sphenoid, to the posterior wall of the sphenoid. It is also accurate despite the type of imaging that you put inside, from the CT to different images rendering in the MRI sequence. And according to this interesting paper, we also know that it is not so important to overcome the anatomic changes during surgery. You know that the navigation system is based on the preoperative images, and it is not important to overcome it during the surgery, because the surgeon really well know which structures is doing, which structures is removing layer by layer. This is our experience. You see that we had, in the last 12 years, 359 transsphenoidal approaches and 42 transpterygoid approaches, not for, transpterygoid, I mean, to reach the destination, not to remove like the maxilla. This is another group of patients. In the transsphenoidal approaches, we use the optic system, Braille Lab, because the neurosurgeons prefer to use the Mayfield head. But in our room, we use the magnetic neuronavigation station Medtronic number 8. In every case, we had a mean error below 2 millimeters. That is sufficient to have a good achievement in surgery. You see that the main complication appear in the macroadenoma more than 2 centimeters in the transsphenoidal approaches, but we will see later. Those are, this is the graphic of showing all the approaches, and you see that we had a very low rate of complications, especially if you take a look to the CSF leak in the macroadenoma more than 2 centimeters, and also regarding the only one case of major vascular injuries on the internal carotid artery. The residual disease is very rare and appear especially in very extensive clival lesions. On regard of transpterygoid approaches, you see that we had just a couple of complications in the group of neuropharyngeal cancer, 1 relapse and 1 residual disease. This is a case in which you see the use of navigation to improve the resection of very small lesion. You see in the imaging a very small chordoma of the clivus, and it's very difficult to reach that destination without the navigation system. You see here a transsphenoidal approach, the assessment of the precision, of the accuracy of the navigation system. Then, in that case, I did a very selective transclival approach, opening up all the posterior wall of the sphenoid. I just skip a bit to spare the time. You see a very selective transclival approach in this case. And then, when I reach the posterior wall, the dura of the posterior wall, with the navigation system, we found out the exactly position of the tumor that was very, very small. And this is the removal of the tumor itself. Okay. This is a case in which the navigation system guides the expert in an altered anatomy. That patient was operated elsewhere and then arrived with a persistent case in our center. That was the persistent case. As you can imagine, the anatomy was completely subverted here. Indeed, we see a lot of scar tissue. This is the assessment of the accuracy of the navigation system to reach the posterior wall of the sphenoid sinus. So we remove all the scar tissue in the sphenoid, and then we move upward to the posterior wall, removing the previous reconstruction. All the nasoseptal flap were used or destroyed by the previous surgery. You see there the remnants of the nasoseptal flap in the previous surgery. And then the drilling for doing a transplanum transtuberculum approach, quite huge. Up to the bottom of the tumor. You see here, the bottom of the tumor was found, thanks to the navigation system, a very difficult and dangerous area. And then here the neurosurgical work. After at least 1 hour of detachment, we were able to remove the wall lesion. And you see inside, and this is a nice view, you see we can reach the posterior part of the aforementioned tumor, and we see the two moral foramen and also the thalamic interconnection that was expanded by the tumor itself. Last case, the navigation is very useful also to assess the limit of the surgery. You see there a relapsing case of nasopharyngeal cancer posterior to the pterygoid, and in this case, you see how I skipped to the view of the posterior wall of the sphenoid. Okay, after the medial maxillectomy. And you see there that we are exposing the posterior wall, opening up the bony part of the wall, and then I assessed the exactly lateral limit of the tumor with the navigation system. You see there. This is the content of the pterygopalatine fossa. So I exactly know where to go to be with a good and sufficient margin to the lateral tumor edge. This is the internal maxillary artery. I prefer to close it to make the afferentation of the tumor, and here the incision to delimitate the lateral edge of the tumor. And then the drilling of the basis sphenoid after looking for median nerve and V2 for sending some samples for the frozen section. Here you see V2. And then the median nerve, the median canal here. Remember that in this case the anatomy was quietly altered by the previous radiotherapy because it's a relapsing case of nasopharyngeal tumor. Here the drilling of the basis sphenoid, and then last but not least the removal of the entire pterygoid process. You see here, together with the tumor itself. This is the insertion of the medial pterygoid muscle. Okay. So, in conclusion, the image-guided surgery in approaching the medial skull-base lesion, yes, it's able to reduce the complications according to the literature and to our experience, reduces, and this is very important, the costs and the indirect costs and the hospitalization time, improve the oncologic results, is cost-effective, and is very useful in the training in a preclinical setting. Thank you very much.
Thank you very much, Dr. Remo. The next speaker will be Eduardo Moreira Serena from Spain. He will talk about the contemporary structural management of the nasal dorsum. Mr. Eduardo is current president of Spanish Society of Facial Plastic Surgery, and he is a European board examination in otolaryngology and head and neck in Vienna from 2011. Yes, please. You have 50 minutes, please.
Good morning, everybody, and thank you very much, Dr. Altamimi, for the invitation. It's a privilege and an honor to be here in the cradle of civilization. I come from Spain, from an island in the Mediterranean Sea called Mallorca. We are not a cradle of anything, but it's a very beautiful island, small island. It's like 50 kilometers to 55 kilometers, the longest distance. We have lots of beaches, we have mountains in the north, we have caves. It's a paradise, and you're all invited. I work in the morning in the University Hospital of the Balearic Islands, which is the big hospital in the lower photo, Hospital Universitario Son Espaces. And I have my private practice in the afternoon in Clínica Juaneda. Those are my contact data in case anybody is interested. So I'm going to talk about contemporary management, structural management of the nasal dorsum. And all of us who work in rhinoplasty, we have seen so many changes in the last years, and we all think, what shall I do? Shall I stay the same? Shall I do the new things that people are doing? And sometimes we feel like dinosaurs watching the meteorite, the Chicxulub meteorite coming down to Earth. If we do not do anything, we will be extincted in a short time. But what do? This is a sign that it's in the west of Spain. It's a region called Galicia, and people from Galicia, they are famous because when you ask them something, they don't answer you. They tell you both things are okay. So what shall we do? Should we do preservation? Shall we do structural? Shall we do open? Shall we do cross? Shall we use piezo? It's a difficult, there are difficult questions because most of us, we have good results with rhinoplasty and we are not eager to introduce any changes. I'm going to go through all these points. I'm not going to talk about preservation, which is another topic, and I will have a presentation on drip rhinoplasty, so I will talk of it tomorrow. First thing is the piezo device, the ultrasonic rhinoplasty. I don't know how is it in Iraq or the Middle East, but now in Spain, if you don't use the piezo, if you don't do the ultrasonic rhinoplasty, patients won't come to you because it has a great name, ultrasonic rhinoplasty. I'm not that sure that is that's better from traditional rhinoplasty, but just the name gets you patient. And what's the piezo electric device? It's just a machine invented by the Italians, by the way, Ramo, and it takes advantage of the piezoelectric effect, which is a quality of some materials that whenever you introduce them or you make them change the magnetic polarity, they change the shape and vice versa. So it creates like a wave that goes through the high calcified tissues in the body, cutting them. Now its use is widespread in surgery. It's not just rhinoplasty, and as many things in rhinoplasty was first introduced by dentists. So this is my piezo. First reports of piezo surgery for rhinoplasty were like 18 years ago. And what's the main difference between piezo surgery and traditional surgery for the nasal dorsum? main difference is that you need a big approach because it's a tool that it's quite big and you won't be comfortable using it under a close approach. But the good thing is that the soft tissues are not damaged by the piezo. So swelling is less, the osteotomy path is much more predictable, and the long-term result of the nasal dorsum is better. We can use it for hump reduction, but I will tell you later that it's better to use the bar for hump reduction. The osteotomy path is a bit different from the traditional osteotomy path. Instead of the triangular path between the lateral and medial osteotomy, we do like a trapezoid shape because it's much more versatile to use in the nasal dorsum. And as I mentioned, we need a big approach to be comfortable using it. So we use the extended open approach. You can see that we dissect right to the nasophageal angle. Of course, that increases the post-op swelling, but that is balanced or neutralized by the less swelling, by the less damage to the soft tissues. So we can reduce nasal humps. We have special inserts for that, like this. But as I said, I don't use it to reduce nasal humps because we have the bars, but you just pass it through the bony vault and it progressively descends. We use it mainly for osteotomies, and we have straight saws, we have angulated saws, and as I mentioned, it's very versatile. You may do more than 2, 3, 4 osteotomies because as you are preserving the internal periosteum, that allows you to do more cuts. Here you can see how I'm doing a lateral osteotomy with an angulated insert of the piezo, and you see that it takes more time. Ultrasonic rhinoplasty takes more time than regular rhinoplasty, but it's much more control. I've been doing regular rhinoplasty for years, and every now and then whenever I was doing the osteotomy, the bone cracked, and then I have a small comminuted fracture, and that was hell. That didn't happen since I'm using the piezo. Second instrument I use is a bar. I don't use rasps anymore, so whenever I want to lower the bony vault, I use the bar. Why? Because it's much more easy, and it's much more progressive, and it also allows me to perform osteoplasty of the nasal walls. We know that some patients have very thick nasal walls, or they have convex nasal walls, and sometimes just with osteotomies we cannot address that. And with the bars we can do it very easily. We can also lower a high radix with that. Third instrument is the electrocautery. Of course, we can lower the cartilaginous vault, and I do it at the beginning with a cold knife. But sometimes it's very difficult to make the cartilaginous vault even, completely even. And with the electrocautery, it gets completely flat and at the same level as the bony vault. When I'm doing that, when I'm lowering the cartilaginous vault, of course, after lowering it, we have to use irrigation to lower the temperature. At the beginning, I was afraid that there was some thermal damage that could worsen the long-term result of the nasal dorsum, but it doesn't appear. So this is a small clip where we can see how I do the average structural approach for the nasal dorsum. First, I remove the osteocartilaginous hump using the knife and the piezo. You see that I'm cutting the bone with the piezo and the cartilage with the knife. And after I have done this, I will regularize nasal dorsum first with the diamond bar and then the cartilage with the electrocautery. Then we go to the nasal walls. I use the angulated saw of the piezo to perform the lateral osteotomies. As you may see, let's go here. As you may see, I don't want the nasal walls to be completely mobile, as I don't join the medial osteotomy with the transverse osteotomy. I leave a small cuff of bone, so there is some stability, and then I reconstruct the internal nasal valve with some spreader grafts. I always use thin spreader grafts because I don't want the nasal dorsum to be too thick on the frontal view. See, I have opened the valve, I put the spreader grafts, suture them. See, and I also suture the cartilaginous bolt and the spreader grafts to the bone. I make a small hole through the bone. You can do it with the piezo, and that makes the reconstruction much more stable. And the last thing I wanted to talk about the contemporary management of the nasal dorsum is the PRF. PRF stands for platelet-rich fibrin, which is something we get from the blood of the patient. Is almost free, for free. It's very cheap, and you only need a centrifuge and centrifuge blood for 3 minutes at 700 RPM, and we get like a yellow section of the blood. That's the PRF, and that is full of growth factors embedded in a tridimensional fibrin matrix that acts for like 11 days. And what do I do with that? I mixed it with ultra-diced cartilage, as you can see at the end of the surgery. I cut the cartilage in small scales, and then in order to further mince it, I put it through 1 cc syringes with knife blades. You see how I do it. I learned this from Süleyman Tas of Turkey. This is a very cheap way to ultra-diced cartilage. I put the cartilage scales inside. Then the nurse is taking the blood from the patient. It's 2 tubes with 8 cc of blood, and immediately after they take the blood, it goes to the centrifuge for just 3 minutes at 700 RPM, and then you see I'm passing the cartilage scales from one syringe to the other through the knife blade, and with every pass the cartilage pieces are smaller and smaller. I do a small hole in the syringe with the cartilage, and then I'm getting the PRF. This is the yellowish part over there, and this is full of growth factors. This is very important in contemporary rhinoplasty too, to use growth factors. I'm mixing them with the ultra-diced cartilage, as you can see, and this is the best filler for the nose, for small adjustments at the end of the surgery. So when I have this, I close my incisions. I just leave the small part without closing, and most of the times I use it for the radix, because when we reduce the humps, sometimes the radix is very low, and we don't want to over-reduce the nasal dorsum. So we put it in the radix. It gets a better radix, and it's much more balanced. You can still sculpt it for a few weeks. It's like clay. It gets harder with time. And combining the ultra-diced cartilage with the PRF makes that resorption is always almost none. So those are some results from patients with rhinoplasty. In Spain, we have patients that have thin or normal skin, a lot of thin skin with huge bones and big cartilages, and you see that those are very stable results. You don't see any irregularity around the nasal dorsum. Patients with crooked noses, we performed a lot of osteotomies, and still the nasal dorsum is stable, straight. Using the nasal bar allows us to narrow the nasal dorsum a lot, the nasal walls, and also working here at the nasal radix. Sometimes we find secondary cases with very thick nasal radix because they did the osteotomies too low, and with the bar we are able to narrow it very easily. This patient, I didn't perform any osteotomy in him. It's just the bar, using the bar to sculpt the nasal dorsum. You can see a straight nasal dorsum, masculine dorsum, and stable. This patient with very crooked nose, very thin skin, that's very common in my country. And you see that the result is really nice. Again, secondary case with very thick radix in the frontal view, and the use of the bars and the piezo allows us to get a perfect nasal dorsum. And this is all I wanted to tell you about contemporary management. You are all invited to Barcelona on November. It's the symposium of the Spanish Society of Facial Plastic Surgery. We will have great international guests and a great time over there. Thank you very much.
Thank you, Dr. Eduardo. Our next speaker will be Dr. Shahzada for transorbital approach to the skull base. He is consultant rhinologist and skull base surgery, University Hospital, Birmingham, and medical director at the University Hospital of Birmingham. Welcome, Doctor. You have 15 minutes, Doctor.
Thank you. Thank you again for the invitation. It's my first time in Baghdad. It's a pleasure to be here. So I'm going to talk about transorbital approaches to the skull base. These are my disclosures, which I don't think are relevant. So a bit of a historical background. It was the early 20th century that the initial orbital surgeries were performed by oculoplastic surgeons, and it was in the 2000s that there was an emergence of transorbital approaches aided by endoscopic advancements. And it was in 2010 that there was the real refinement in some of the transorbital approaches, led by Chris Moe from Seattle, Castelnuovo and Delan in Italy, and Darlene Lubber in Cape Town. It's a multidisciplinary approach with ENT surgeons, oculoplastic surgeons, neurosurgeons, and sometimes maxillofacial and plastics. It's a corridor. It's a corridor through the orbit, and that approach can be through an upper eyelid approach. It can be a lateral retrocanthal approach, medially or inferiorly, and each offers access to the orbit either anteriorly to the side, to the skull base, or into the cavernous sinus. The techniques, so I mark the patient with my oculoplastic surgeon before they have their general anesthetic, so they're sitting up, and we mark in a skin crease. So the incision is low down, it's not high up, it's on the thinnest bit of the upper eyelid, and it's where the oculoplastic surgeons would do a blepharoplasty. So it's a cosmetic incision that's done. Then there's subperiosteal dissection to the bone. If we need to remove temporarily the orbital rim, we do, and then depending upon where the tumor is, whether it's intraorbital, intraconal, or whether we're using the orbit as a corridor and we're going intracranially. And then hemostasis and reconstruction. So the corridor gives us four areas: the superior, lateral, inferior, and medial walls, and they each give us access to specific parts of the anatomy that we might want to approach. The entry level to transorbital surgery is doing balanced thyroid eye disease. So if you do endoscopic endonasal, then with your oculoplastic surgeon, start doing the lateral decompression through a transorbital approach, through an upper eyelid approach. And essentially, this is optic canal. You've got superior fissure here and the infraorbital fissure. In the balanced approach, you drill laterally until you get to the temporalis fascia. Very anteriorly, superiorly, you might access the frontal sinus. And then a sphenoid wing meningioma would be the greater wing of the sphenoid, where that intraosseous component pushes the eye out, causes subluxation and an orbitopathy. In recent years, there's been a huge number of publications which have led to more and more clinical indications that we're learning about as we're learning this anatomy. We're doing orbital tumors, we're doing skull-based tumors, I've mentioned meningiomas, epidermoids, CSF leaks, not only of the orbital roof, but if you've got a CSF leak that's very lateral in the roof of the sphenoid, then actually a more direct approach, a shorter approach, a quicker approach is that transorbital window. And then intracranial tumors operating in the cavernous sinus. It's not just one corridor. We add the transorbital window to other corridors, and quite often in most of my patients I will join it with an endonasal approach and a transorbital approach that will then give me more versatility to approach the tumors, whether it be orbital or in the skull base or intracranial. Let's look at a case. So this is a case that maybe we're more familiar with. This is a coronal CT scan. We've got here V2, and we've got a defect that's lateral to V2 with a meningocele that's coming down and an active CSF leak. This patient is a recurrent patient. She's already had an endonasal repair. It worked for 4 years, and then she had a re-leak, got meningitis, and was referred in. I decided to do this through a transorbital approach. Let's look at her CT scan. So we can see there is a defect. There's a very narrow cleft initially. So if we're doing another approach, this is the defect we can see just here. If we're doing another endonasal approach, we'll need to get a 70-degree angle scope. We need to really look at the bony neck of where the defect is. What we don't want to do is just to pack the sphenoid. That doesn't work. So here I've done my upper eyelid approach. This blue is blue celastic that's just holding the periorbiter so that I don't injure the fat. We then gently drill away the bone of the greater wing of the sphenoid. It's an extradural approach. So it's only me and my oculoplastic surgeon. And I lift that middle fossa dura, and my cockle here drops into the defect. So I've dropped into that defect that is just lateral to V2. This approach means that I'm less likely to get V2 numbness. I've used fascia lata of the patient, and I'm now pushing that fascia lata in. That's going to separate the intracranial cavity with the nose, and the patient's had a successful repair. Let's look at some other cases. This is sphenoid wing meningioma. So far we've done 18 in Birmingham in the UK. All but 2 had at least 2 lines of improvement in the Snellen chart. What does that look like? Well, it's 2 jumps, so wherever your starting point is, we're bringing patients from not useful vision to useful vision. Our average improvement or reduction in proptosis was 4.4 millimeters. Let's look at a patient. This is a 57-year-old lady, a typical patient who's got a progressive loss of vision. She's already had a transcranial approach. We can see the titanium reconstruction, and the intraosseous component has grown again. She's now losing vision, and she's got some proptosis again. So we want to target this part of the meningioma. We're going in through our upper eyelid approach, extended by about 1 centimeter laterally to give us further space. And we start endonasally going in with a medial decompression, because we're going to have 5 or 6 instruments through there. So we need space. And then going in, we can see here use of image guidance, and we're drilling away laterally that intraosseous component of bone. We can take away intraorbital component of meningioma. If there's a big intracranial component with your neurosurgeon, you can come in and remove that as well. What's the outcome? So the patient's vision improved, the proptosis was better. This is the before and after CT scan showing that decompression, showing again that decompression as well as a medial decompression. So the average in our 18 patients, and published data by Darlene Lubber and Italian group, Dalan et al. Have shown, again, a very good comparable outcome compared to the conventional orbitozygomatic approaches, the much bigger transcranial approaches. Other lesions, if we look at trigeminal schwannomas, we had a middle fossa talk earlier on, but compared to the conventional approaches for trigeminal schwannomas, this is a paper by Dusek in Korea. The transorbital approach gives the best rates of gross total reduction than any other approach. I haven't done anterior clinodectomy or petrous apex aneurysms, etc., from this approach, but there are lots of reports now of teams, and it is teamwork, progressing and reaching those areas. What are the complications? Well, a lot of patients will have some temporary edema of the upper eyelid. That lasts for a couple of weeks, and then it improves. There are techniques that we can use to try and reduce that. The risk of ptosis, CSF leak, diplopia, vision loss is less than compared to the orbitozygomatic and transcranial approaches. The strategies that we use, we work in teams. I work mostly with my oculoplastic surgeon when I'm doing this. We do a multi-layered closure, careful dissection. We do use image guidance for all of them, and careful, proper planning.
Doctor, you have 2 minutes left. Okay.
Done in 1 minute. Okay. A bit like the skull base surgery, there are levels of difficulty, and when you're starting learning this technique, start with the simpler approaches. Start with your balanced decompression in your thyroid eye disease. So as the ENT rhinologist, you would do an endonasal decompression. With your oculoplastic surgeon, do your upper eyelid approach and drill away through that window until you get to the temporalis fascia. And then you'll be confident then maybe to move up to your intraconal, extraconal lesions, your meningiomas. I put it to you that it is a safe and effective approach for selective lesions. It requires, as all surgery, anatomical mastery. and it complements other routes. It doesn't replace other routes. It complements endonasal and open routes in modern skull-based surgery. I'd like to invite you to a course that I'm running in Edinburgh at the end of May. You're all welcome. Thank you very much.
Thank you, Doctor, for this nice lecture. The next and the last lecture speaker in this session is Dr. Alfred Aga from Albania. He will speak about the reconstructive options in head and neck surgery. Dr. Alfred, he is the president of the Albanian ENT head and neck surgery. Also, he is a member of the Italian Society of ENT. Also, he is co-founding member of the Albanian Medical Education Association. Please.
Good morning to everybody. It's my second time here in Iraq, and it is a pleasure. I want to thank the organizing committee and Dr. Light for the kind invitation. I will start about topics that is not very common and very easy to talk about it, but as a head and neck surgeon, it's one of my favorite topics. I started my residency in 2007 in Brescia with Professor Antonelli and Nicolai, and my mentor was Professor Piazza. In the beginning, in Brescia, we have the strategy to front the surgery with head and neck reconstruction only and with free flaps, and it was our standard of care. Every week we have 2 or 3 cases of free flaps, but we use the pedicle flaps only in a few cases because the strategy of Brescia school was clear and the gold standard was the free flap surgery. But in 2013, when I was in conference, I met Professor Hayden, and I find another way of thinking, and it was very interesting reading even his editor in head and neck reconstructive surgery in current opinion. The Professor Hayden, after explaining the history of microvascular free flap surgery, he think that it's the time to change our strategy. That is not important for the surgeon to do every time free flap surgery, especially in elderly patient, but it's a time to change our strategy and to think in the oldest way to rediscover the old flap that we used in the 18th years. Recently, the history, he told, has repeated itself. In the last 15 years, when you rediscovered simple pedicle flaps, such as the submental and supraclavicular flaps, were introduced for head and neck reconstruction, their broad obstruction was resisted, this time by the surgeons who were heavily invested. This is the battle with head and neck microvascular reconstruction and the surgeon that used pedicle flaps. In this article, regional flaps start to have a more important space in head and neck reconstructive surgery, and I will talk in this lecture about the pedicle flaps that we use most. I don't want to lose time to speak about cervical-falcial flap, dectopectoral, and pectoralis major that all of you have a huge experience, I think. I want to talk about some flaps that we are using more and more, like a buccinator modified flap or jaw flap. Is a flap very easy to harvest, and it's very useful in oral cavity surgery. As we can show in this video, we have a defect of the floor of the mouth. We start to prepare our flap. Is a buccinator flap. We remove all the buccinatory muscles, but we don't use the flap as a rotational flap, but in this case, we start to harvest the flap, and when we finish to harvest the intraocular part of the flap, we used to do a tunnel dissecting all the facial artery, and we put the flap on the neck. It's very easy, and you, after doing this, you have a free flap in the neck. You can use this buccinator flap as a free flap because you have the mucosa, the muscles, and you have even the vessels that are attached. You don't need to do any anastomosis, and you have a perfect flap that you can use for cheek reconstruction, for floor of the mouth reconstruction, for tongue reconstruction. This is the flap on the neck after we perform the neck dissection. This is the vitality of the flap, and it's perfect. And the most important thing now is to put the flap under the mandible in the way that you don't have any problem with the mobility of the flap. Because when you reconstruct the floor of the mouth, it's very important to have a thin flap, and the flap needs to be very, very thin and mobilized very easily, because otherwise the patient can have problem with speaking. It's a young patient, 40 years old, and after we finished the suture, we can have even the results of the surgery. We use the B-shot flap to reconstruct the cheek, and even this procedure is very standard and very easy. And this is better to perform to avoid trismus after the surgery. After we finished, this is the final results. The cheek with B-shot, and this is the final results after 2 or 3 months. The patient can speak very easily. If we do the flap with rotational flap, we can't have this mobility of the tongue, and the patient can have problem with speaking. You can use the same strategy even in the tongue surgery. I can show you only the last part of the flap. This is the flap on the neck, and this is the final result. It's a perfect match, and the healing process is very quickly. After 2 weeks, you have a normal mucosa. Another flap that we use a lot is a submental flap. It's a flap introduced by Martin in 1993, but after the modification of Patel, we used even in different cases when we need some muscles. And in this case, there is another modification because in the beginning, that was a lot of cases that the flap was failed, but the problem was that sometimes the venous drainage is in the external jugular vein, not in the internal jugular vein. Now it's very important to preserve even the external jugular vein. We use in a lot of cases, especially in the parotid region tumors, because it's very easy to harvest during the dissection. This is an extended subtotal parotidectomy. We find the facial nerve with retrograde way, and after we finished all the parotidectomy. We perform the neck dissection, and we start to perform, this is the neck dissection, and we start to harvest the flap. This is the part of the harvesting the flap. You have isolated the fascial artery and the vein, and you know the drainage vein. It was from internal jugular vein or external jugular vein. This is the reason that you can avoid any failure of the flap. In this case, we put together the flap, even the digastric muscle and the malleoyoid muscle, the right side. This is the way to protect better the vessels. And after we remove the flap, we can rotate this flap even immediately in the parotid region. There are a lot of studies that explain that you can do this flap without compromising the oncologic security. You can remove the lymph nodes of first level without any problem, and the vitality of the flap is preserved. Now we are removing all the submandibular gland from the flap, because the vessels are the same. And after we try if the flap is vital, we can close our defect very easily. And all this procedure is 2 or 3 hours. It's not a long, especially in an elderly patient. You avoid to do flaps like free flaps or other flaps that are very expensive and for the patient is not very easy. These are other 2 cases that we use the flap. In the right side, you can see, in the left side, you can see that the result is fantastic. The patient is perfect. Even after radiation therapy, the flap is okay. Even the mismatch of the skin colors is perfect. We use even in check reconstruction or in tongue reconstruction. Like in this case, we use the submental flap to reconstruct the hemiglossopelvectomy with this flap. Another flap that we use a lot, but the first 2 are very, very common, is the supraclavicular flap. We can use as a free flap, but even as pediculate flap, especially in oral cavity or skin of the neck. In this case, we have a skin defect on the parotid region with a tumor that infiltration even the skin, and this is the result. This is another case that we use the supraclavicular flap for the tongue reconstruction. After we remove the tumor, we can hemiglossopelvectomy. We prepare the flap, and we can use in this case, we choose this flap because the other option are not very good for this type of patient. And the result is very, very good. I want to spend a few words even for the free flaps. My old favorite flaps are the radial forearm flap and the anterior thigh flap. But usually now we use only the anterior thigh flap and the fibular flap for bone defect. The anterolateral thigh flap is very easy to harvest, and I think it's a very good flap for all the defect of the head and neck region. In this case, we have a skin tumor that infiltrate even the orbita. And after removing all this lesion, including all the masticatory muscles and infratemporal muscle, we preserve the eye in the beginning, but after frozen section, we see that it was infiltrated, and we go to remove everything. After this neck dissection, we try to reconstruct with anterolateral side flap. This is the defect after the neck dissection. And we use this flap. ALT flap is very big in this case because we need a lot of tissue. After isolating the vessels, we put the flap on the defect. This is the results after 2 weeks, and we have the results after radiation therapy after 6 months. I think it is a good result in this case. We can use even combined flap. In this case, we start with hemiglossectomy, including the mandibular infiltration. We remove and block 2/3 of the tongue and the tonsil and the mandible. And after removing all these defects, we need to close all these defects. We need bone tissue that we can take from the fibula and ALT flap to cover the defect of the tongue. In this case, we use 2 flaps from the same leg, and the patient, it was very young with a big tumor, and after putting the fibula, we used this piece of skin for the monitoring of the flap, and this is the ALT flap. In conclusion, the goal of reconstructive surgery is functional and cosmetic rehabilitation. Local regional flaps offer different advantages compared to the free flaps in terms of short hospitalization and economic cost, especially in developing country like my country. It's very useful to use this type of flaps. Free flaps reconstructive remain the gold standard in selected cases, especially when you need bone material. Sometimes the pedicular flap can become the first choice. Pectoralis major flap and the ALT flap are the most used flaps in our hands. Thank you.
Thank you very much for all speakers and audience. Now we have a coffee break at Lille Hall. Thank you very much.
كافي بريك حيكون بقاعة الليل. Second session start at 11:15. Second session start at 11:15.